This is Karen's story. It's a story of a journey no mother would willingly take. For on this journey, the road can be rough, often accompanied by feelings of helplessness, anxiety, and despair. But to begin at the beginning, Karen joyfully anticipated the birth of her second child. A healthy 9-pound boy was delivered, much to the delight of Karen, her husband Jim, their daughter Nikki, and the wider family. They named him Thomas. The early days were so carefree as they watched him grow and develop his endearing personality. They all took such delight in this charming, mischievous boy. But Tom was a little slower reaching some milestones than his sister. He walked at 18 months, but that's not so unusual. And boys do tend to talk later than girls, don't they? Lately, however, she had been anxiously watching his development and becoming more and more concerned. Despite reassurances from medical professionals, she felt sure that something was not quite right. 2 weeks ago, her worst fears were realized when the pediatrician gave a probable diagnosis of Duchenne Muscular Dystrophy. They were told the condition is both progressive and life-limiting. And while often passed on to a son by a mother, who, though seemingly unaffected, is a carrier for Duchenne, it can often arrive completely out of the blue as a new or sporadic mutation in the gene responsible. It is very common for parents to respond to their grief in different ways. While Jim is finding it difficult to come to terms with the diagnosis, Karen is concentrating on being as positive as she possibly can be as she researches to increase her knowledge and plans the essential first steps on this unexpected and unwelcome journey. Possibly the most important guide on the journey will be a primary care physician who will have experience in the care of boys with Duchenne, and wherever possible, be committed to active management by a multidisciplinary team.
So when a family comes to us for the first time, most important thing for me is to sit and listen to them, to learn what they've been told, to learn how they've been told, to learn what they understand. Because so much of their life has changed. This is a huge change in their life, something they never expected and something they never wanted to happen. So it's important for me to understand where they are, where they've been, and what they've been told, because some families, tragically, have been told that there's nothing that can be done. Their son is going to die. They should take their son home and take care of him and give him love. And that today is just not acceptable. So the first thing I want to do is to know where they are, what they've learned, and what they would like to ask me in terms of questions, because oftentimes the families have a lot of questions and a lot of confusion. Parents say to me, where can I get information? And with internets now and access to information, information is everywhere. So they need a way of listening to information, learning what they need to know so they can make an informed choice. Because I think parents need, with all the information they have today, they have to balance things. They have to know what the risks, what the benefits are, and what their choice is going to be. So that's the first step for me. The second step is to assemble a team, to make sure that the key steps have been done. The key doctors have been seen, for example. I want to make sure that they've had the genetics testing done, that they've been given proper advice, because the genetics information is so important. It not only tells them what they can anticipate, but it also is exciting because there are new treatments coming down the pipe that are going to help these boys live a better life. It's also important for the family, for other siblings, and for sisters and other members of the family. So I want to make sure that genetic piece is in place, that they understand what the information is and how they can use the information. And the second thing is to start to assemble a team. A team that's going to come in and out of their lives for the next several years. It's going to include physicians, it's going to include therapists, physiotherapists, occupational therapists, social workers, psychologists, all sorts of people who are going to help them in their challenges to interface with their new environment and their new challenges. So the team is going to be important for them for many, many years. And the third thing I try to do soon, maybe not the first visit, but certainly by the second visit, is to look at the future, look at treatment, and to explain that we now have to plan for a long life. Not a short life with no hope, but a long life with treatment options. And one treatment option that we're particularly familiar with and comfortable with is the use of corticosteroids. So we bring up the issue of corticosteroids for these boys fairly early in our meetings. It's not the perfect drug, it's not without some side effects, but it's the only thing we have today in order to help these boys live a longer and a better life. There are new things coming along, and likely they're going to be added on to the corticosteroids. So there'll be sort of a mixture of different components, different molecules, and steroids that are going to be part of this life of treatment for the next few years. And so that then leads me to the fourth thing that I really like to leave them with, and so that they feel comfortable phoning me, accessing my email and my phone. I have what I call a phone clinic. So between 7 and 8:30 in the morning, I'm there. They can phone me, and we have a very high connection rate. It doesn't waste their time. It's effective use of my time. So being available for them is a big asset for them, and I want them to know that I may not know the answers, but at least I have a connection around the world through various networks that if I don't know the answer, I can certainly try and find it out for them. And the last thing I say is you have to have hope. Whatever you've been told before, you have to have hope, because there's important new research coming, there's important new treatments coming, and we have to prepare for these boys for a long life. They're going to be going to college, they're going to be working, they're going to be living independently, and that's what we need to plan for today.
A consultation with a geneticist was recommended to confirm the diagnosis, identify the specific mutation, and to explain the implications for them as parents and for the wider family.
It's very important to have a molecular diagnosis early on in the course of muscular dystrophy. The first thing it does, it allows you to confirm the clinical impression of the disease. It confirms the diagnosis and often assists in classifying the disease. The second thing it does, it allows you to work out whether the mother of the child is a carrier of the disease, which has implications not only for her health, but also the health of her female siblings. If she is not a carrier, then no one else in the family need be investigated to determine whether they are carriers or not. If the mother is a carrier, then that allows her to have accurate information on which prenatal diagnosis can be based in future. It's also important for her own health in that she is at risk over her lifetime of developing a cardiomyopathy. If she is a carrier, she is at risk. If she's not a carrier, she's not at risk. There are many evolving treatments for muscular dystrophy. All of these hinge on knowing exactly what the mutation is in the family. Therefore, it's critical early on in the disease to establish what the mutation is in your family. The mother will have to access these services by contacting either a specialist neurologist or a specialist clinical geneticist that are affiliated with a molecular diagnostics laboratory in their centre.
The role of the physician in charge of the neuromuscular team will include liaising with clinical genetic services to ensure the diagnosis is accurate. They will prescribe and monitor any medications such as corticosteroids. They will review his progress every 6 months or more frequently if it is required. They will be able to provide information on current therapies, research projects, and clinical trials. The physician will coordinate the care provided by members of the multidisciplinary team and make referrals to other medical specialties when needed. This would include a baseline assessment from the cardiologist and a preliminary visit with a pulmonologist.
I'm always happy to meet the families of young children with Duchenne. Not because it's important that I take care of their children. They don't really have a lot of respiratory needs in the first 6 or so years of life. Certainly, I'd like it to that they don't need my help at all. But number one, it's very important that the children get immunized once a year against influenza, and that they receive the full immunization series for pneumococcus, and we give the older children Pneumovax. But also, they need to know who their resources are. I want them to know who I am, how to reach me in case of any troubles. But it's very important for families to know who can help them.
Physical therapy will be most important right from the time of diagnosis to give advice on appropriate active exercise and activities, and because there is a lot that can be done to prevent or lessen the development of secondary complications of Duchenne. The physical therapist will monitor gross motor development, muscle strength, his functional abilities, and the range of his movement in his joints. The PT will be able to give advice on the type of activities, which will give him enough exercise while not causing any harm to his muscles. One of the most important ways parents can help is to do regular stretching exercises to retain the range and flexibility of the muscles and joints. Stretches do need to be done every day. The calf muscle and the heel cord tendon are usually the first to show tightness. Therapists will provide a stretch program for these particular muscle groups, which are known to tighten. Tendo Achilles, or heel cord stretches, are often started very soon after diagnosis. Lie the child on his back in a comfortable position. Then cup his heel firmly in one hand, while resting the sole of his foot on your forearm. Stabilize the leg with the other hand. Then pull firmly on the heel while pushing the sole of the foot up with your forearm until the stretch is felt in the calf. Another group which sometimes needs attention is the hamstrings at the back of the thigh. For this one, he lies on his back again. With one hand under the heel and the other over the knee, the lower leg is gently raised to straighten the knee. It is easy to stretch the hip flexors with the child lying on his stomach. Cup the bent knee in your hand and allow the ankle to rest on your arm. Apply a little downward pressure on his bottom to prevent it from moving. Then pull the leg upwards and inwards toward the other leg. This will also stretch the iliotibial band, which runs down the outside of the thigh, and sometimes tightens in the early stage, especially when boys walk with a wide base. Boys tolerate stretches if it can be their special time of the day, after a massage or warm bath, and in conjunction with story time or other pleasurable activities. It is wise to make it as routine for him as brushing his teeth. Once parents are comfortable performing the daily stretches, the physical therapist will need to make regular checks to ensure that they are being done correctly and to make any adaptations that may be needed. Position the child so that he is well supported and comfortable. Stabilize the joints which are not being moved. The intensity of the stretch should be submaximal and should never cause pain. If the child resists strongly, another method must be employed. The stretch should be held for at least 30 seconds and repeated 3 times. Overstretching is to be avoided as the muscle responds by contracting further. If the boy actively resists, a lengthening contraction occurs which may cause further damage to the muscle fibers. Aquatic physical therapy, or any form of swimming, provides a wonderful form of exercise for a young boy. It will exercise all his muscles in a less demanding way than activities on land. At the outset, it is important to make him feel comfortable and ensure he enjoys the water. The primary goal is to promote water safety and to achieve independent swimming as soon as possible. He will need to learn breath control. Although some boys cope with learn-to-swim classes with regular swimming coaches, therapists may recommend beginning lessons with a group of boys who have similar abilities, or alternatively, it may be better for him to have individual lessons with a therapist or teacher who is familiar with the condition. Focusing on conventional swimming strokes and stroke correction is not always a good idea, and some boys find hybrid strokes easier and less tiring. Swimming should be fun for him, as this is an activity he will be able to enjoy throughout his life. Advice on all musculoskeletal aspects of Duchenne. Recommendations on the type and level of active exercise. Aquatic physiotherapy and swimming instruction. Instruction and supervision of stretching exercises. Monitoring lung function and providing respiratory therapy when needed. Monitoring the spine. Orthotics advice, including manufacture or referral to an orthotist. Advice on aids and equipment. Advice on suitable recreational activities. Liaise with schools and be a consultant on all activities of a physical nature. Provide education to all those involved and advocate for the child and family. At some stage in the early years, the physical therapist will recommend night splints to help keep the range of movement at the ankle. To make them, the PT or orthotist may take a cast of the child's feet so that the splint will be an exact and comfortable fit. Casting is an easy process which isn't painful at all. From the cast, a splint will be made which will go from the end of the toes to behind the knee. It can be made of many different materials. This one will be made of a polypropylene thermoplastic material with a lining on the inside. The splint should normally be worn for between 6 or 7 hours during the night, and by doing that, the ankle will be kept at 90 degrees for the duration of his sleep, rather than pointing downwards and weighing down by the bedclothes. Research has indicated that the range of movement in the ankle is maintained best by a combination of stretching and the use of night splints. The occupational therapist on the team will perform assessments to measure Thomas's early development in a number of different areas. Among other things, she will look at his general level of development, his perceptual ability, and his fine motor skills, and assess his ability to process and make sense of sensory information. Thomas is performing very well. Had there been any problems in any of the tests, the therapist would offer an early intervention program with the aim of encouraging his independence in all aspects of daily life, as well as preparing him well for the school years ahead. She will give Karen ideas to help her develop his skills. A referral is often made to a child neuropsychologist who would assess his cognitive abilities to identify if there are any of the problems known to be associated with Duchenne. Although most areas of learning are strong, Some, but not all boys have well-documented learning difficulties associated with the development of language, verbal memory, and focusing attention. Any of these factors can affect his ability to read. An assessment in the preschool years is recommended. Check developmental levels and milestones. Assess for possible differences in ability to process sensory information and provide strategies to help manage this in everyday life. Assist with development of fine motor skills, adaptive skills, and self-care skills if they are delayed. Evaluate learning style. Boys with Duchenne are usually visual learners. An OT will introduce learning strategies as they are needed. Provide information on housing, equipment, and transport options for later years.
Say, can you get your monster? We'll just leave the snake over here or the monster can't see. Can you get your monster to go round and find all the words? Let's start up here with Mr. Monster. All right, you start.
A speech-language pathologist is a very important member of the team in the early years, as a delay in language development is often the first sign of Duchenne. Research conducted by Dr. Jos Hendrickson in the Netherlands has found that 35% of boys with Duchenne have serious reading and spelling problems not in accordance with their IQ.
In Holland, we do a research on the reading problems and the higher risk for reading problems for the Duchenne boys. We started that research several years ago now, and we found that there is a higher risk for some of the boys. So we have developed a protocol in which we have a standard assessment for every boy when he is age 4 to find out whether he has problems with what we call phonological awareness, which is the key to reading learning. And there are procedures and methods to assess phonological assessment, phonological awareness. And when you do that at the 4-year boy, you can find out whether they are at a higher risk. And if so, you can start early intervention, because we believe that the best treatment is to early intervene when there is a higher risk to prevent later problems. What is tremendous important is a good assessment of the speech and especially of the language. So my advice would be to get a good, thorough assessment of a language with language therapists.
Sam! Have a look, Sam.
Boys with Duchenne may have difficulty learning which sound corresponds to a written letter. This leads to an inability to decode the letters quickly into sounds and words. When quick and automatic decoding skills are not mastered, reading becomes difficult for the boys. Speech-language pathologists and teachers are able to provide an intensive early intervention program for boys in their preschool years. These programs have considerable success in preventing later reading difficulties. Some of the strategies include discovering the initial sounds in words and breaking the words into sound bites.
What's that?
Starfish.
A starfish. Can you hear that noise again? Sim the turtle. Sim, there he is. And
Awareness of letters, sounds, and words may be fostered in a variety of ways, employing a multi-sensory approach to learning.
We made lots of things ready to trace with your finger and say.
Using rhyming ditties and games can also enhance phonemic awareness. Early identification of boys at risk of developing difficulties is crucial. Parents can then seek professional help, and they can also contribute themselves at this early stage. Simple strategies such as reading books, asking questions about the content of the story, and having the boy retell the tale can contribute greatly. He will develop a love of reading and an understanding of the written word, which is so important for his future education. Assess and monitor language and speech development. Assess and monitor literacy development. Provide early intervention for language, speech, and literacy. Provide learning strategies.
Thanks for sending in your 3-day food record. I had a chance to put it through the computer and analyse it, so I can give you some feedback on that today. So what I'll do today is to go through the basics of what a healthy diet is and also give you some more specific feedback on the food record that you sent in for me. I'll start with the basics of good nutrition. In this brochure here we have a general guide to healthy eating.
Boys with Duchenne are often advised to consult a dietitian soon after diagnosis, and particularly before steroid medication is begun. Healthy growth in children relies on the correct balance between intake of food and the energy used in their daily activity. Because boys with Duchenne are less active, it can be quite a challenge to maintain a healthy weight. The addition of steroid treatment may create an additional challenge, as the appetite is often increased with a subsequent and often unacceptable gain in weight. The extra weight can negate the benefit of the steroids to the muscle by making them work so much harder. A healthy diet includes a wide variety of nutritious foods, plenty of fruits and vegetables, breads, cereals, rice and pasta, preferably of the whole grain varieties. Protein foods such as lean meat, poultry, fish, eggs, nuts or legumes, and dairy products such as milk, cheese, and yogurt. It is important to drink plenty of water rather than juices or carbonated drinks, which contain large amounts of sugars. Fats and oils such as butter, margarine, and cooking oils should be used in small amounts only. Other high-energy foods such as potato chips, fries, cookies, chocolate, and other fried takeout foods should be eaten only occasionally or in small amounts. A healthy diet is important for all children, but particular care should be taken when boys are having steroids. It is advisable to discuss your child's diet with a registered dietitian who can advise on healthy food choices and monitor his progress.
Following the diagnosis of Duchenne muscular dystrophy, parents will be experiencing some of the painful emotions of grief as they adjust to this new situation in their lives. At this early stage in their journey, I would encourage parents both to care for and support each other, and to seek out and accept support from their wider family and amongst their friends. I would also encourage parents to access support groups. It can be really helpful to meet with other parents going through a similar situation and to hear some of their ideas and perhaps to put some of those ideas into practice. Support is also available through the therapists and social workers at the neuromuscular clinics. The Parent Project Muscular Dystrophy can help parents to access both support groups and neuromuscular clinics. With regard to behaviour, parents can have the same expectation of their son with Duchenne muscular dystrophy as they do of their other children. However, should behaviour prove to be a challenge, and this can sometimes be the case, then support is available. The Parent Project Muscular Dystrophy can help parents access this support too. Siblings will need support too, and recognition of their own grief, particularly as they become aware of the limitations of their brother's condition. Siblings often feel left out, and some parents have found it very helpful to set aside special time for the siblings, perhaps one at a time. Perhaps they might go to a movie or watch a sport snack together and then perhaps finish up with a milkshake and take some time to talk together. But just taking time to be with the sibling and listening to them is so valuable. Overall, at this early stage in their journey of caring for their son with Duchenne Muscular Dystrophy, I encourage parents to take time out for themselves, to care for themselves, and to look for and accept the support of others.
Although a diagnosis of Duchenne may seem reason to despair, it is important to know that help is available from many sources.
I like to keep in contact with Parent Project. I think they give you a tremendous amount of hope, in particular in regards to research and really about care of your child with Duchenne Muscular Dystrophy. It's incredibly important to keep abreast of what's going on around the world and to have that hope.
My hope for Aidan is that he will live a normal, happy, healthy life.
My hope for Cade for the future is that he is able to continue his steroids until there is help, to the point where there is the bridge in his gene that's going to match and he's able to live a normal, healthy life.